Good day, everyone. My name is Michael Miscoe with Miscoe Health Law, and I'm happy to be here this week for the Facebook Live presentation hosted by ChiroSecure. And we're going to talk about what I would call COVID-related post-payment audit liability, focusing on telehealth. But before I get into that, of course, last month we talked about telehealth and we went through the rules. And I think I didn't even have my headset back on the desk, and those rules were changing. And of course, over the past month, the rules have been very fluid relative to telehealth. We did get some questions following the presentation, and I thought I'd like to just follow up with addressing some of those issues. First and foremost, as cool as it sounds, there are no Tele-PT or teletherapeutic exercises or anything other than telehealth evaluation management related or counseling services. So please do not get creative with telehealth, and be cautious. I just hung up the phone with one of my contacts in the Blue Cross post-payment audit department, and looking at their expectations relative to telehealth. Also read um, uh, an OIG report relative to their analysis of telehealth in South Carolina, where they determined a 98% error rate. So with COVID impacting how providers practice, how much they practice, most practices are down anywhere from 50 to 70%. And because of the changing rules relative to telehealth, and that providing some option to provide compensable services during this COVID thing, uh, I fully anticipate in the wake of this, after this is all said and done and we're back to our normal lives, which is hopefully in the not too distant future, payers are going to look at what their payment liability relative to telehealth, and I fully anticipate telehealth and COVID related post payment auditing to kind of kick into high gear. Now, relative to chiropractic, as we discussed last month, one of the things that has changed is that at least Medicare has concluded that telehealth is only appropriate for established patient visits. They are not allowing physicians to initiate management of a condition via a telehealth E&M service. So I had thought that patients could call, you could have a televisit. Certainly you can do that cash. And of course, where physical examination, personal examination is necessary, then you should schedule that patient in the office. Most states are permitting healthcare practices to operate, but they have some very ambiguous rules as to the type of patient you can see. Here in Pennsylvania, they say no elective services. In theory, but they don't define what elective services is. And the guidance that I gave is, look, if a patient has an acute condition and they're undergoing restorative management, classic medically necessary care, for those of you that bill third-party payers, that would probably be permissible. Maintenance, palliative, preventive, the patient's coming for their once-a-month treatment. Those are the types of services that probably would not, unless it was a supportive care plan where the patient's condition would regress. That said, we talked about some telehealth opportunities, but my concern is that you're going to be submitting claims, place of service to a modifier, something like 95, whatever, telling the payer it's telehealth, which means it's going to be very easy for commercial payers to audit telehealth services. They're easily identifiable. And there are a variety of codes out there, and I'm not going to go through that review again because we don't have time. But if you're billing telehealth services, obviously there's no telehealth to Medicare, but to commercial payers, work comp, auto, make sure you understand what the payer rules are. Now, if you're in a state where they follow Medicare, then you need to understand Medicare's telehealth rules. And those rules are changing. They're pretty solid now. And I reviewed the latest iteration of what Medicare is requiring. There's softness on the originating site, where the patient can be at home rather than go to a physical telehealth location. I don't see any relaxation or changes by the licensure boards permitting you to evaluate a patient outside your own state or a state where you're licensed to practice. The originating site, meaning where the patient is, defines where you have to be licensed to practice. So there could be some licensure related analysis by insurance companies. And then, of course, um, looking at the type of service insofar as was it a service that was appropriately performed via telehealth. Certainly, where you're following patients, providing home care, instructions for patients that aren't comfortable coming to the office to continue treatment, that raises a number of concerns, which we'll talk about in a minute. Uh, Definitely want to reiterate that evaluation management, which is history examination, decision making, examination's a little tough, other than things that you can observe visually. Um, you know, Plan of care, counseling is where I see the biggest telehealth opportunity, specifically related to instructions for self management, risk factor reduction, possibly for patients that have a nutritional component to their treatment plan, where obesity is a comorbid condition to their musculoskeletal problems. That sort of work can be done telemed, and certainly any telemed that you're doing for cash is appropriate. And we talked about some of the informed consents that you might consider implementing before doing telehealth services. From a post-payment liability perspective, we're only worried about claims that you're submitting to third-party payers, of course. Um, so, you need to be very, very careful to understand what each payer's rules are, because you cannot assume that they're all following Medicare or that they all have the same policies, because they don't. And it's one of the more um, maddening things about this telehealth thing. Everybody's crowing about telehealth. How do we do it? How do we get into it? Because you're losing money hand over fist because your patient volumes are down. But be very, very cautious going after that money, because it's going to be highly audited on the backside of this COVID thing. As I mentioned, don't try to provide any skilled exercises, supervision of exercises via telehealth and billing, physical medicine procedures. That is definitely not going to fly, because there is no allowance for it anywhere. I haven't seen anybody come up with that policy, although I've been asked that question a lot. And while I think it's a novel idea, where you had synchronous communication with a patient, and they had the capability and the materials, the equipment to do exercises at home, a way to provide skilled intervention. I know no payer that is authorizing payment for uh, remote um, telehealth skilled intervention for physical medicine procedures. The other issue that I think we have to embrace or think about relative to COVID is that we have a couple classes of patients. Certainly, patients that initiated care prior to the shutdown, which all of a sudden started limiting people's movements. In which case, so we start a course of care, maybe you're a week or 2 weeks in, and then the COVID things hits, and then the patient terminates care. Now, the COVID thing issue and the stay-at-home orders and all that stuff are going to eventually um, be lifted. Now the patient comes back into care. And here's my concern. Okay, the patient obviously survived for 6, 8, 10, we don't know how many weeks it's going to be, without care. And then all of a sudden, we're going to resume the care plan that started before the stay-at-home order went into place. And a payer would reasonably question the necessity of the care that you're starting back up, because if they were okay while they were at home, why did they need to come back now? And maybe you were even doing some home intervention or home activity risk reduction guidance and home instructions, and they're better now. They obviously didn't need care during the COVID scenario, and now reinstituting that care plan, I think, raises some medical necessity issues. It's kind of like patient runs out of visits, and then all of a sudden on January 1st, when they have new visits, there's no new injury, there's no nothing, and all of a sudden we're billing again. It doesn't make any sense from a medical necessity perspective. So if you're going to bring a patient back into care after the stay-at-home order is lifted, you need to very, very carefully track in your documentation what that patient's experience was when they were without care. That their condition didn't resolve, that they were in agony or whatever they did to try to temporarily minimize symptoms pending the ability to return to care. You cannot just pick up where you left off and say, oh, Joe Smith is here today and he has the complaints of, and you do a salt note from a note like 2 months ago. That is not going to work for you, and it is a recipe for disaster. So be very, very cautious there. The other thing I'm concerned about is, given the duration of these stay-at-home orders, that may limit the frequency at which patients present to the office. So you have a patient with problems, but they are not presenting to the office on and what would otherwise be considered an optimal or restorative type care schedule. Normally, that care is 2 to 3 times a week in order to justify that you have an expectation of causing significant improvement in a reasonable, predictable period of time. What if the patient's coming ad hoc or once a week or once every 2 weeks? Those types of visit schedules are superficially maintenance, palliative, preventive. They're not covered. It's one of the most difficult challenges that we have to deal with when a payer does a medical necessity audit and the visit schedules a once every plan. There's no argument that we can submit to justify that is appropriate restorative care with the appropriate expectations to make the care medically necessary and covered, as that term is defined by the payers. So be very, very cautious. If a patient can't get in on a normal restorative care schedule, you may have to consider transitioning them to cash and hopefully picking up a plan on the backside. But this COVID crisis, to the extent that it's a crisis at all, it's certainly a crisis for your practice, is certainly going to present some medical necessity challenge that, from data analytic perspective, a lot of these cases are going to get picked up, and it's really unclear how payers are going to deal with it. In speaking with a payer financial investigation provider review team today, broached this question just to see what their thoughts were. They haven't really thought hard about it, but essentially it's whatever cases or whatever providers their data analytics spit up to them, they'll look at them. And if the care looks medically unnecessary, then they're certainly going to audit it and try to recover the money. So be very, very cautious about your billing patterns during this period of uncertainty where patients are at home, they're not presenting to care frequently. Especially watch your telehealth. And I want to point out, the reason that the OIG audit came up with a 98% error rate was documentation. Providers did not document start and stop times. They did not document with sufficient detail the counseling that was performed during the telemed encounter. So if you are doing those, be sure you document them exquisitely well: when it started, when it stopped, what you talked about with some degree of detail, and how it related to management of the patient's condition, so that you can justify that the work was reasonable and necessary. That's all we have time for today. I hope that is helpful, and we'll see you again next month. Everybody have a great day.